Hello, I'm Ileana Piña. I'm professor of medicine at Thomas Jefferson University in Philadelphia, and this is my blog. We have talked a lot in the past about potassium. Why is potassium so important in heart failure? It's because a lot of docs are afraid to give some of the drugs that will raise the potassium because then you need to deal with it, and everybody is afraid of hyperkalemia causing arrhythmias. To calm those nerves, just remember that arrhythmias only occur when the potassium is suddenly going up. This chronic hyperkalemia that occurs with many of our drugs usually, I can't say every time, but usually does not result in arrhythmias. But now we've got potassium binders, and you've heard me talk about the potassium binders in several of my other chats with you, and they work. We have primarily two of them, and the first one that ever came out was patiromer, and now I'm going to talk to you a little bit about the zirconium C cyclosilicate. Uses sodium as its exchange ion. Whenever you take out one ion, you have to put another one in, and it's sodium. Maybe if you use it in the higher doses, you can give the patient more edema, or you can make the patient actually congested with more fluid. So years ago, we did the DIAMOND study, and the DIAMOND study was a patiromer study, but in essence, we found that you could continue to give the drug, particularly the mineralocorticoid receptor antagonists such as spironolactone or eplerenone, as long as you had the patiromer as your safety net, and that the drugs were well tolerated and the adverse events were significantly less. So now let's talk about the REALIZE trials. They wanted to prove basically the same thing, that the patients could be started or kept on their spironolactone as long as you had that backup of the zirconium cyclosilicate binder. And so they picked patients who had HFrEF, so low ejection fractions, and low ejection fractions was defined as less than 40, and they were already on guideline-directed medical therapy, but not the MRA. And they divided up the patients right from the beginning between those who were already hyperkalemic, in other words, they had potassiums of 5.1 to 5.9, which is when docs start getting worried and concerned about it. GFRs had to be better than 30, and if the potassium was not yet okay, they were given the zirconium cyclosilicate, normalized the potassium, and then they entered the study. The second group had some history or were at risk for hyperkalemia. Maybe their GFRs were lower, but their potassiums were somewhere between 3.5 to 5. They started with about 366 patients. These trials have not been huge, certainly not what we normally see in heart failure trials. The group that had hyperkalemia ended up being about 95 patients, and the group that were normokalemic ended up a little bit higher, like 271 patients. Then they were randomized, and now about 102 went into the potassium binder, and the other group went into the placebo. And they continue the study, and they continue to check, had the patient come off the drug, had the patient had to reduce or remove the spironolactone. They are the older patients, who are in mostly the early 70s. This was an international trial. There were not that many patients from North America, but they had quite a few patients from Europe and some patients from Latin America. A lot of diabetics, this is what we see in diabetics, AFib, all the same comorbidities that we really know a lot about. And the class 3 and 4s were about 16, 17%. The rest were class 2. So this is really the ambulatory population. NT-proBNPs were elevated. They were close to 1,000, 1,200, and the GFRs were either in the high 40s or about 60. The patients were pretty well medicated, including the RAS inhibition, the beta blocker, and even the SGLT2 inhibitors. So this is a very typical population, and what they wanted to see is what happened. Did the patients remain on the binder and were able to tolerate the spironolactone? And in fact, that was the case. So at the end of the study, more patients had been able to be staying on their spironolactone, which is that one drug that we're not doing so well on when you look at large databases. And if they were on the zirconium drug, they were more likely to stay on the spironolactone. They even did a sensitivity analysis, which really showed that it was consistent across the board. So now we have two binders that have shown to us that the patients could stay on their drugs. There were some interesting findings here, though. There was more edema, again, small numbers, everything is in small numbers, and there seemed to be more heart failure events in the group that had the zirconium cyclosilicate. The first episode of hyperkalemia was delayed or didn't happen at all. Again, the hyperkalemia was controlled. What does that tell you? Well, the exchange is sodium. And there had been reports before that at the higher doses, if you gave this binder, you would have more retention of sodium. I think the hint in this trial, even though the numbers are very small, is very similar to that. But apparently, according to the investigators, these were issues that could be resolved. Probably an increase in your diuretics, or having the patient remember to be careful with their sodium intake so they don't retain more fluid. My message to you is that use these binders, whichever one of the two you want, or whichever one of the two your hospital has available for you on their formulary, because it may give you that sense of comfort and self-efficacy that you can actually start the MRA and keep the MRA. The MRAs are life-saving drugs, and the patients with HFrEF need to be on them. And this is a way to do it without having to sacrifice your true GDMT. This is Ileana Piña. Thank you for joining me today. Signing off.